Hello, everyone. During the past several months, we have learned a great deal about patients suffering from the coronavirus, including the serious morbidity and mortality associated with this disease. The daunting challenge of saving a patient who develops severe acute respiratory syndrome coronavirus is just one clinical challenge. But the necessity for urgent or elective surgery introduces a whole new level of complexity. Here are my disclosures. The virus-induced inflammation as a result of the coronavirus triggers a cytokine storm causing tissue factor release, thrombin generation, fibrin formation, which is designed to coat the virus and prevent the spread and replication of this dangerous virus. That's a great mechanism, but unfortunately, the side effect is thrombosis. This inflammatory process triggers thrombin generation, which produces hypercoagulability, which can be measured with a D-dimer. Deep vein thrombosis, pulmonary emboli, stroke, or arterial thrombosis may occur. Microthrombosis may occur in the lungs, liver, kidney, and brain, manifested as organ insufficiency or failure. Fibrinolysis may occur to dissolve the thrombin and thrombi which are forming throughout the body. A disseminated intravascular coagulation-like picture can result in thrombosis or bleeding depending on consumption of clotting factors and platelets. This disease is very heavily linked to Virchow's triad, which are the three factors associated with the development of venous thrombosis. You have stasis, hypercoagulability, and endothelial dysfunction and damage. And the punchline here is that venous thromboembolism is seen in nearly 40% of ICU patients in some studies, compared to only 2 to 3% of those that are on the wards. We must remember that Covid-19 is an endothelial illness involving the entire systemic vascular tree. And these patients can present with pulmonary emboli early in the disease. This may be the result of local activation of kinins, for example, bradykinin 1 and 2, on the endothelial cells. And as such, the lung environment is prone for local vascular leakage leading to angioedema. It has been proposed that by blocking the kallikrein activity, there might be an ameliorating effect on early disease, preventing the respiratory distress syndrome in some cases. In addition, the pathway might indirectly be responsive to anti-inflammatory drugs. And as a matter of fact, some investigators have advocated the early and heavy use of corticosteroids, among other drugs, to inhibit this process. This diagram depicts the mechanism of inflammatory thrombus formation in sepsis. Both pathogen-associated molecular patterns and damage-associated molecular patterns can stimulate monocytes through specific pattern-recognizing receptors expressed on the cell surface. Activated monocytes can release cytokines and chemokines that activate platelets, neutrophils, and endothelial cells. The monocytes and other cells release extracellular vesicles that can express procoagulant tissue factor and phosphatidylserine on their surfaces. And here you can see how these reactions lead to the formation of damaged endothelial cells. The neutrophils play pivotal roles in the activation of this coagulation process and damage of the endothelial cells. And finally, an important feature is the inhibition of fibrinolysis by the release of plasminogen activator inhibitor. When one looks at the variety of these changes and reflects on heparins and low molecular weight heparins, we have known for a long time that there are a variety of non-anticoagulant effects of these agents. And many of the effects of these agents on inflammation can be seen in this lengthy list. Now, what about scoring in these patients? Since they all should go on heparin or low molecular weight heparin, why have a score? Well, the Caprini score is one that has been used because it's a thorough history and physical. And as the number of risk factors goes up, the incidence of clots goes up, and as the power of each risk factor goes up, that makes a clot more likely depending on that power. And putting that all together, one comes up with a score that shows a linear and nonlinear increase in various populations to the incidence of venous thrombosis. A group of us have come together with a consensus statement from the American Venous Forum outlining some of the considerations, particularly regarding risk assessment. All patients should be scored on admission, and the reason for this is that that score reflects their comorbidities. And we know that young people without comorbidities survive this disease without a problem, but older patients are at much increased risk. So this is a way to define that risk. In addition to that, routine coagulation tests should be done initially and serially. And in addition to all patients receiving heparin or low molecular weight heparin, those patients that have a score of over 8, we recommend doubling the prophylactic dose. Also, at discharge, it's important to do a final score based on what's happened during the hospitalization and extend that chemical prophylaxis with those patients who have a score of 8 or those with multiple comorbidities, particularly cardiac failure and excessive BMI. Therapeutic anticoagulation is suggested for some selected patients, and we remind you that routine ultrasound is not recommended. Further considerations include daily reevaluation of lab values, respiratory status, and clinical picture. One should choose between heparin and low molecular weight heparin based on the clinical situation, including bleeding risk, renal insufficiency, and so forth. Direct oral anticoagulants are not recommended during hospitalization, but may be appropriate following discharge. We would also note that other scores, such as the Wells score, can predict the incidence of VTE, but it doesn't account for all comorbidities. Nevertheless, it's useful to guide therapeutic anticoagulation or duplex scanning. Post-discharge prophylaxis and follow-up are critical. So in these surgical patients, with all of the risk factors that are associated with the virus, as well as the patient's own risk factors, there's an increased incidence of arterial thrombosis, DVT, PE, stroke, fatal thromboembolic events, and that requires careful risk assessment and appropriate thrombosis prophylaxis for the at-risk period, especially following discharge. I'd like to thank everybody for listening to this presentation. Invite you to go to venusdisease.com for more information, and have a nice day.